Welcome to the 2023 Basic and Clinical Science Anesthetic course of the European Society of Anesthesiology and Intensive Care. It is a true honor for me to once again be part of this course. So I want to thank you all, the organizing committee and the scientific committee. My lecture is about neuromuscular blockade agents and the anatomy of the neuromuscular plate. My name is Victor Pinho Oliveira. I come from Portugal, from Viseu. These are my conflicts of interest regarding this presentation. And I usually, when people ask me, where is Viseu, I tease them with this. If you consider Portugal to be a cell phone, Viseu is the place of the rear camera. My hospital, public hospital, is a non-academic with 600 beds hospital. The city has about 100,000 inhabitants, but we care about 500,000 people in our healthcare religion. We are midway between the mountains and the sea. And I will do my presentation in the following 30 minutes, outlining by this way. The first 10 minutes I will consider it the basics of the neuromuscular junction, the motor neuron, the junction by itself, acetylcholine, its synthesis and its receptors. The next 10 minutes regarding drugs, neuromuscular blocking agents. Then we will talk finally on neuromuscular blockade monitoring, the methods, muscle sensitivity, the patterns of stimulation, and last but not least at all, the postoperative residual neuromuscular blockade. So first things first, the basics. I'm also an EDAIC examiner, part 2 EDAIC examiner, and we focus a lot on the basics, the physiology and the anatomy. The motor neurons are the nerves that control skeletal muscle activity. They originate in the ventral horn of the spinal cord and travel up all the way to the muscles they supply. The cell body of a neuron, it's at its proximal end, and the information travels from here down to the axon. Axons are about 10 to 20 micrometers in diameter and are surrounded by this myelin sheet produced by the Schwann cells. The Schwann cells act as an insulator to speed up the nerve conduction. So this myelin sheet is interrupted by these nodes, the Ranvier nodes that you see here, that can do this saltatory conduction, that can speed up even further the conduction. Each motor neuron connects to several muscle fibers to form the motor unit. The number of muscle fibers within the motor unit varies enormously depending how fine is the motor control needed for that muscle. For example, the muscles of the eye have a lot more motor units than the muscles of the thigh. So regarding the basics, the neuromuscular, we have this three parts of the neuromuscular junction. The first, the presynaptic terminal, then that's the synaptic cleft, and then the postsynaptic receptors. That's the main constitution of the neuromuscular junction. And the electrical impulse is transmitted along the motor nerve, causing presynaptic acetylcholine release, binding it to the neurotransmitter to the postsynaptic acetylcholine receptors. This occurs at the motor end plate. So acetylcholine receptors, neurotransmitters are gated channels that open very shortly and that lead to a major influx of sodium and a lesser extent an efflux of potassium. So the opening of the channels at resting potential leads to this major influx of sodium ions. Digging it a little more inside, the presynaptic terminal is composed of the Schwann cells. The Schwann cells are cells that serve a structural function. They are very important for the nerve homeostasis, the maintenance of the neuronal homeostasis. They produce dystrophic factors, In addition, the Schwann cells also provide stability, and they participate in the axon development and synaptic formation from the fetal state and throughout life. Schwann cells control the number of neuromuscular junctions and remove superfluous ones in presynaptic nerve terminals, especially during reinnervation, for instance, after a crush injury. The neuronal acetylcholine receptors, the presynaptic receptors, are pre-junctional nicotinic receptors. They have also 5 subunits. They have this positive feedback role. They inhibit when stimulated by non-depolarizing neuromuscular drugs. They inhibit acetylcholine mobilization. With depolarizing neuromuscular blocking drugs, they stimulate acetylcholine. And as you know, acetylcholine also is part of this presynaptic terminal. Acetylcholine is formed from acetyl-CoA and choline, derived from the pyruvate acetyl-CoA and the choline from extracellular fluid, and it's stored in 2 major pools: the reserve vesicles, 20% of it, and the ready releasable vesicles, most of it. So on the synaptic cleft, this narrow cleft that contains acetylcholinesterase, the proteases that will act on acetylcholine, they have this ionic site where it is bounded, and the stereotic site bounded to the serine group, and it is able of hydrolyze about 10,000 molecules per second of acetylcholine. The post-junctional, the third part of the neuromuscular junction, it's made up of folds and crests. In the folds, there are very high sensitivity of acetylcholine receptors. In the crests, there's the place where the voltage gate sodium channels exist. The acetylcholine receptors, the nicotinic receptors, very highly density on the folds. They are made of these polypeptide, 5 polypeptides that form an ion channel, and we have 2 types of them: the mature ones, junctional receptors, and the immature or fetal extrajunctional receptors. So the mature adult junctional, they are composed of 2 alpha, 1 beta, 1 gamma, and 1 epsilon subunit. They are highly conductive, and they open for a very short time open. By opposition, the immature fetal extrajunctional receptors, they have 1 gamma instead of an epsilon subunit. They are induced after upper or lower neuron injury, or after burns, or after sepsis. They are highly sensitive to succinylcholine, and they stay longer time open. So they promote an efflux of sodium, and this is the cause, the physiological cause of why we have cases of hyperkalemia when in these clinical situations, and burns and major crush, major trauma, because of this type of induced immature extrajunctional fetal receptors, acetylcholine receptors. So immature fetal extrajunctional receptors, just to get it more clear, they are produced, they are upregulated during upper or lower motor neuron defect, after prolonged chemical innervation, after direct muscle trauma, tumor inflammation, burns, thermal trauma, disease atrophy, or severe infection, and they are upregulated, increased on these situations. Moving on for the second part, drugs, neuromuscular blocking agents. When you see this lamp sign on my slides, that's a typical question that we examiners like to do to our candidates, to see how comprehensive and the knowledge is of the candidate. So when we ask which kind of mechanisms of neuromuscular blockade do you know, they most frequently only refer the fourth one, the last one, blocking acetylcholine receptors, but there are another kinds of mechanisms, like, for instance, preventing acetylcholine synthesis, preventing its release, or depleting acetylcholine stores. And the most important for clinical, for us anesthesiologists, is this one, by blocking it. So, but remember that we have drugs or toxins that also prevent neuromuscular blockade throughout these mechanisms. Another question that we like to pose is, what is for you the ideal neuromuscular blocking agent for you. And we kind of like the candidates that are organized, mentally organized, and they start telling the physical properties, the pharmacokinetic properties, and also the pharmacodynamic properties. So ideally, a neuromuscular agent physically should be cheap and water soluble, should have a long shelf life with no special storage requirements. Pharmacokinetically, should be a short acting with a predictable reversal, non-cumulative, so we can use in infusion in intensive care settings, for instance. It should be completely metabolized with no active metabolites, not affected by renal or hepatic impairment. Pharmacodynamically, it should have a rapid onset of action with a high potency, low dose high potency, without any cardiovascular or respiratory side effects, and should be safe for pediatric or pregnant patients, and ideally with a non-depolarizing mechanism of action. So this is our taxonomy of known neuromuscular blocking agents. We have two big families, the depolarizing ones, the non-depolarizing ones. The depolarizing one, the only short-acting that we have, succinylcholine or succinyltonium. The non-depolarizing ones, we have a further division, the aminosteroidal compounds and the benzylquinolinium compounds. So the aminosteroidal with intermediate action, pacronyl, rocuronyl, long action, pancuronyl, and pipacuronyl. The other, mivacurium, dentacurium, cisatracurium, or tetracurium. So a short notice just to refresh the pharmacology. Succinyltonium, it's a junction of two molecules of acetylcholine joined by this ester linkage. It promotes the reversal depolarization of the acetylcholine receptor, so that's why we see the muscles fasciculating. But because of this slow breakdown of the two molecules, it prevents further transmission, and it is during this the neuromuscular junction is blocked. We have this blockade of the transmission. Excreted mainly, the 10% excreted in the urine. It's hydrolyzed by the plasma cholinesterases, has a lot of side effects like myalgia, the increased risk of cardiac arrhythmias, especially on pediatric patients, the hyperkalemia, the anaphylaxis, malignant hyperthermia, and is strictly contraindicated on severe muscle trauma after the first 24 hours after burns until it's 18 months from the burn, on muscle diseases, as we mentioned before, because of the upregulation of the immature or fetal acetylcholine receptors, postsynaptic receptors. The non-depolarizing agents, the two big families, the minosteroidal and the benzylquinolines, they do not alter the conformity of the receptors, the acetylcholine receptors, so that we will not see any contractions, any fasciculations. They have this reverse binding to the alpha subunits of the receptor, and the metabolism is by diffusion from, to plasma, and they have highly ionized drugs with a small volume of distribution. They are mainly concealed in the plasma, in the extracellular fluid. So, atracurium, benzylquinolines, it's metabolized by two main metabolic pathways, the ester hydrolyzase and the Hoffman elimination. The Hoffman elimination, as we all know, is the non-enzymatic spontaneous degradation at the body pH and temperature, and it has this inactive laudanosine, inactive metabolite that is thought to promote hyperleptogenic properties. This is the doses, the onset time, the duration. It has no direct cardiovascular effect known, but it may promote histamine release, so it's not advisable in cases of allergic, or may promote anaphylaxis, and is also associated with clinical illness, myopathy. The other benzylquinolinium drug, the cis-atracurium, the cis isomer of atracurium, this is the clean version that has the desired clinical action, 3 to 4 times more potent than atracurium. It is also metabolized by the Hoffman, the spontaneous metabolization of pH and temperature, and it has less production of laudanosine, the metabolite. These are the dosage, the onset time, and the duration. It has does not release histamine. It has greater cardiovascular stability and is useful for the critical illness infusion. Moving to the immunosteroidal compounds, vecuronium, this amine that is eliminated in urine, undergoes hepatic metabolism that with active metabolites, so it should be avoided repeated doses in cases of renal or hepatic disease. The dosage, the onset time, and the duration is the one that is shown, and it has also not the property of releasing histamine and no cardiovascular effect, and this has this partial affinity to sugammadex. Rocuronium, it was named to be the rapid onset curonium. The rocuronium is 6 to 8 times less potent than vecuronium and excreted in urine and bile. It is completely antagonized by sugammadex without any active metabolites. We have two dosage, the one for a normal onset time to 0.6 milligrams per kilogram with this onset time, but if we need a rapid sequence induction, you can double the dose, and we have a shorter onset time, and we can have it used in the case of a rapid sequence induction. It has also minimal histamine release with mild valvulitic properties. That's why we see the increase in the heart rate when we administer it. It is painful at injection, so patient must be unconscious, obviously, and useful also for critical illness infusion. We have these factors that affect the duration of the non-depolarizing neuromuscular drugs. Concomitant use of allogenates, isoflurane, the sevoflurane, the pH, also the acidosis affect the duration of non-depolarizing neuromuscular drugs, the temperature, the age, hypocalcemia, hypokalemia, renal or hepatic disease. We have the drugs, and we have also its reversal agents. The most ancient, inhibitors of the acetylcholinesterases, they neostigmine, hydrophonium, they inhibit the acetylcholinesterases. It prolongs the half-life of the acetylcholine, potentiating its effect and replacing the acetylcholine that increased in the synaptic cleft, replaces the non-depolarizing neuromuscular blocker. Block recovery must be established before administration of either neostigmine or hydrophonium, and it has muscarinic side effects because of this increase of acetylcholine. More recently, we have the cyclodextrins, the sugammadex. It's this toroid cylindrical structure with a lipophilic core and a hydrophilic tail that encapsulates rocuronium fully, and to a lesser extent also vecuronium in the plasma. And this complex of sugammadex and rocuronium is excreted in urine. Because of this mechanism of action, it has no muscarinic effect, but there are reports of increased prolongation of the QT interval and severe bradycardia reports in the use of sugammadex. Moving further to the third and last part of our talk, neuromuscular monitoring. Why is it so important? The first statement, neuromuscular monitoring should be used for all patients who receive neuromuscular blocking agents during anesthesia, either to guide the dosing of the neuromuscular blocking agents and its reversal, either to assess the degree of spontaneous recovery. So why should we monitor our patients? Because we use very dangerous drugs. We use them to facilitate endotracheal intubation. We use it to allow better mechanical ventilation. We use it to improve surgical conditions, but these are dangerous drugs. And the consensus is increasing. There's a huge increased consensus on the need of monitoring these dangerous drugs that we use. This is a 2018 consensus group that stated clearly that quantitative objective neuromuscular blocker monitoring should be used whenever a non-depolarizing drug is administered. Subjective and or clinical tests of neuromuscular blocking are not predictive of adequate neuromuscular recovery and are not sensitive to the presence of residual weakness. So it should be abandoned in favor of objective monitoring. Also, these most recent recommendations of the associations of anesthesists published in 2021, they published recommendations, and it stated clearly that quantitative neuromuscular monitoring should be used whenever neuromuscular blocking drugs are administered throughout all phases of anesthesia, from initiation of the blockade until recovery of a TOF ratio superior to 0.9. Every operating theater or location where drugs are used should be equipped with a quantitative neuromuscular monitoring device. Even most recent, and you have the QR code to check for the article, the American Society of Anesthesiologists practice guidelines for monitoring and reversal of the neuromuscular blockade. This year, they were released in January of this year. They recommend that to use quantitative neuromuscular monitoring at adductor policies to confirm the recovery of a TOF ratio superior to 0.9. Sugammadex recommended for deep, moderate, or shallow levels of blockade induced by racuronium or vecuronium. Neostigmine, it's a reasonable alternative for a minimal blockade that is between 0.4 to 0.9 of the TOF ratio. And it also states that patients with adequate spontaneous recovery with a TOF ratio documented to be over 0.9, identified with a quantitative monitoring, do not require pharmacological antagonism. So this growing consensus for monitoring, it started in 2010, and it's most updated now into I need to update with the new ASA guidelines 2023. This the ongoing growing consensus for the need of monitoring the dangerous drugs that we do use on our daily practice. How can we do that? There are classically three types of the clinical tests, the qualitative tests, and the quantitative tests. The clinical should not be used, the qualitative should not be used, we should use quantitative monitoring. Why you should not use clinical tests, the grip strength or the head lift? Because they are unreliable, they are not specific, they are not sensitive. So the neuromuscular blocking management guided solely by clinical evaluation can result in residual paralysis. The qualitative monitoring, this ancient stimulation, direct stimulation of a nerve, and the visual or tactile assess of the response. They are more reliable than the clinical tests, but very difficult to subjectively evaluate the difference between moderate levels of block or fade. We are not able to detect the presence of fade more than 0.4. So qualitative evaluation also does not eliminate the risk of postoperative residual paralysis or curarization. So quantitative monitoring, it's the use of a neuromuscular that stimulates peripheral nerve, records, quantifies, and displays this evoked response. There are a whole lot of techniques to do that high mechanomyography, electromyography, acceleromyography, lots of some of them are more on investigational ground. These are the most common types of monitoring techniques that we use. The mechanomyography, it's precise, reproducible, and it's considered to be the gold standard. But most recently, the acceleromyography is the most widely used technique, and it is being considered de facto the standard of care. There's another lamp sign because the acceleromyography uses the second law of motion of Newton, and if you say this to your examiner, you will surprise him, because we have the piezoelectric sensor that we know its mass. We measure the acceleration, so with this we can calculate the force. So the basis behind the acceleromyography is the second law of motion of Newton, and with that you can highlight your knowledge of physics applied to clinical settings. Moving on, where should we monitor the neuromuscular blockage? most typically, adductor pollicis muscle, the ulnar nerve, the adduction of thumb, we should set up the electrodes like the shown in this picture, with the negative more distally and the positive more proximally, yes. But also we can monitor it on the facial nerve, either on the orbicularis olli or the corrector supercilii, the eyebrows, the eyelid or the eyebrow, putting the electrodes like this one, the negative and the positive electrodes. Please be aware that the facial nerve, its recovery response of the muscles may not reflect the full degree of recovery of the other muscles. So if we only have available the facial nerve to monitor the neuromuscular blockade after surgery, we must, when we have ulnar nerve available, we should use it to confirm an adequate reversal before extubation. So whenever we need to use, for instance, in surgeries that we are not able to reach the limbs, we should not extubate the patients before confirm adequate reversal on the adductor pollicis. Also, posterior tibial nerve can also be monitored. It's also described to be a monitor in this setting, but if we are using a paralyzed limb, we should not perform it because there is upregulation and an exaggeration of the ratio and underestimation. Just a little note on the differential muscle sensitivity to the blockade. The central muscles are more faster to be blocked, the larynx and the diaphragm, and more slower in the peripheral muscles. This is related to the increased blood flow and increased delivery to these muscles. But recovery is also faster in central muscles than on peripheral muscles. So this is the increasing, the most faster is diaphragm, laryngeal muscles, and or corrugator, abdominal, to all the way down to the abductor, most peripheral muscle. So why this is important in clinical settings? Because at intubation, if we have a TOF count of 0, we can assure that all the pharyngeal and diaphragm muscles are blocked, and so we have optimal intubation conditions. During surgery, a 0 TOF does not guarantee the diaphragm is paralyzed, and we will have a surgeon shouting that we have to increase our blockade. And during recovery, a TOF ratio over 0.9 represents full recovery. Yet the airway and muscles are fully recovered with that when measuring it. So monitoring the facial muscles will overestimate the degree of recovery, so we need to add the adductor pollicis. Just a simple, very quick patterns of stimulation. We have typically 4 types of patterns: the single twitch, train of 4, tetanic, and double burst stimulation. The responses differ between depolarizing and non-depolarizing block. The train of 4, most commonly known a supramaximal twitch of 2 Hz in 2 seconds, counting the number of twitch evoked, and the ratio is the amplitude of the 4th response by the first one. The fade is this decrease between the T4 and T1, the 4th and the 1st response, and that's the main difference between when we are using non-depolarizing and depolarizing neuromuscular blockades. As you see, we have the fade when using non-depolarizing, and when we are using succinyl, the depolarizing, we don't have this fade. And we have the phase 2 block when we do large doses of succinyl or repeated doses or continuous infusion of succinyl. The phase 2 block is characterized by the fade in these kind of situations and this post-tetanic potentiation. We also have the correlation between the TOF count and the degree of neuromuscular blockade. When you have 1 count, we have more than 95% of receptors still blocked, and when you have the 4 counts, we have 75, but we still have 75% of the receptors blocked. So we can only consider the 0.9 as our cutoff to avoid residual colorization. post-tetanic count, we apply this tetanic stimulus and then do short stimulus at 1 Hertz per second. The tetanic stimulus mobilizes the acetylcholine release and has this post-tetanic facilitation, and it is useful clinically to assess the deep levels of neuromuscular block below TOF count of 0 responses. Double burst stimulation, it was considered, and it's no longer used clinically. It was used when we use subjective evaluation of the blockade. Just a short notice on the incident of post-residual neuromuscular blockade. This is an article from 1979 that reported that the train of floor of less than 70% patients arrived to the recovery room, 30 patients, 42% of the patients arrived with less than 70% of the recovery. And we may think that the incidence would change with time. This most recent study from 2019, 40 years after that, the Viggy Morgensen study, and we can see that overall 65% still arrive at the recovery room with the TOF ratio below 0.9. So this is still a problem. This is still a pandemic that we must be aware of. So the clinical post-operative residual colorization is related to the increase of pulmonary complications, to the need of more oxygen requirements, more incidence of hypoxemia, more critical events, and also it is associated with obstruction of the upper airway. This is a very useful chart published in the anesthesia to guide us through the use of rocuronium by the differentiating what is the profound, the deep, and the moderate. And my take-home messages are these ones. The clinical tests for monitoring the neuromuscular block are insensitive, they are non-specific, and they are unsafe for detection of residual weakness. Objective monitoring documenting a TOF ratio above 0.9 is the only method to assure recovery of full muscular function, and postoperative residual blockade is associated with increased risk of aspiration, prolonged recovery room stay, hypoxemia, airway obstruction, and increased postoperative pulmonary complications. So these are my references, and this is a very interesting picture applying art with anesthesiology. So thank you for your attention. I will be at your disposal to answer your questions. I have this question. It's a true or false question regarding neuromuscular blocking monitoring. Does true or false qualitative evaluation ensures elimination of the risk of postoperative residual colorization? B, the celeromyography is based on the second Newton's law of motion, such that the force exerted by the thumb is proportional to the measure of acceleration, since mass doesn't change. True or false, neuromuscular monitoring should not be performed on a paralyzed limb due to the upregulation of acetylcholine receptors after the innervation and the variable exaggeration of the train of flow in paretic limbs. True or false, after neuromuscular blocking agent administration, the blockade occurs faster in the peripheral muscles than the central muscles? And true or false, objective monitoring documenting the TOF ratio above 0.9 is the only method to assure recovery of neuromuscular function? Thank you so much.